So my name is Dean Kellogg. I'm an internal medicine resident from San Antonio. And just spoiler, I don't know, I snuck in. So spoiler alert, I don't have cath lab experience. I don't have an eloquent structural intervention that we've just heard about. So I'll do my best to not put you to sleep for the next 5 minutes, maybe do some board review. So this patient, a 60-year-old gentleman, he has a history of HFpEF and refractory AFib. He ended up getting referred to our hospital with worsening CHF, now had class 3 symptoms. They thought it was due to a PFO from an ablation he had had 3 months prior. As an outpatient, he really didn't have any other history. He reported having a history of hypertension, so CHAD basket 2 and was anticoagulated. On exam, he was normotensive, but he had really profound right and left-sided CHF symptoms, JVD, S4, ascites, lower extremity edema up to his sacrum. And really, the labs, no proteinuria, normal creatinine, significantly elevated BNP. His EKG was a normal sinus, inferior Q waves with some right ventricular hypertrophy and low voltage. On echo, he had a preserved EF, severe diastolic grade 3 dysfunction with ED ratios in the 29 and 21, grade 3 diastolic dysfunction, severe LVH, enlarged RV that you can see here, and an elevated pulmonary artery systolic pressure. So just another view of the left ventricular hypertrophy. And then this was the culprit PFO that he was referred to us for. And it really was not very impressive. It's a small, not very high velocities. There's another view of it. He did get a cath from an outside institution, which confirmed the pulmonary hypertension. It was probably WHO class 2 with an LVEDP of 23 and no significant coronary artery disease. So we admitted him for a heart failure exacerbation, diuresed him, but really ran into problems with symptomatic hypotension, inadequate urine output, and it just kept getting worse. So we kind of questioned this PFO causing his refractory heart failure and broadened our differential to some of these other things. And the one that really stuck out for me and what we ended up working up was amyloidosis. So we did that with a cardiac MRI that showed diffuse gadolinium enhancement characteristic of amyloid. And then his hematologic workup kind of confirmed that with bone marrow biopsies and immunofixation. So this was the final diagnosis. I think some of the challenges we faced were anchoring bias. We just kind of went with what we were told. It's also pretty rare for amyloidosis to present just with pretty much isolated cardiac symptoms. And we definitely ran into a lot of problems with the diuresis along the way. So just some board review. Think about amyloidosis whenever you have unexplained heart failure, and early diagnosis and treatment is really important. Once CHF symptoms start, the 50% median survival is 6 months without treatment, and that goes up to 47 months with treatment. And these are some of the other classic buzzwords for amyloidosis. Low voltage EKGs, like we saw with the pseudo-infarct pattern. Classically, it presents with nephrotic syndrome and peripheral neuropathy, which we didn't see in this case and made it more difficult. Don't treat them with ACE inhibitors or beta blockers. The calcium channel blockers are contraindicated because it can deposit along the amyloid fibrils. And regardless of the CHADS-VASc, anticoagulation is indicated because on autopsy, there are up to 50% of patients with amyloid have intracardiac thrombus. And then really quickly getting to chemotherapy is important for prognosis. Thank you.
Just one question. Very nice presentation, and I'm
Thanks.
very impressed at your level of detail, especially given that you're not even in cardiology training. So that's very impressive. I think you guys were spot on to the chance that the iatrogenic small ASD that was created following the pulmonary vein extubation is very unlikely to be the cause. One thing to keep in mind on the differential for anybody who's had a previous AFib ablation is always think about pulmonary vein stenosis too. That's something that should be considered on the differential, although probably not with overt heart failure symptoms like you guys saw.
Thank you.
Thank you.